How do you know when back pain is becoming the kind of problem that may require surgery? Most people don't find out until a spine surgeon's name is already on their referral. But there are three warning signs that show up before that point, and every one of them is something you can check for right now. I'm Dr. Subir Rao, triple board certified in pain medicine, anesthesiology, and functional medicine. I've treated over 20,000 patients across the country over the last 20 years. What I see consistently is patients who had several of these signs for months, sometimes years, before they ended up in front of a surgeon. In most cases, those signs pointed to a specific gap in how they were being treated, a gap that, if addressed earlier, would have changed where they ended up. Here's what I want you to know before we get into it. Even if you recognize all three of them right now, surgery does not have to be what comes next. There is a whole tier of interventional therapies called minimally invasive spine surgery between where you are and that outcome. By the end of this video, you'll know each sign points to and what the right next step actually looks like for you. Sign number 1, your pain travels from your back into your leg. When your back pain travels down into your leg and follows the same path every time into your calf or your foot, that's your body tracing a nerve. That's called radiculopathy, which basically means a nerve root in your spine is being compressed or irritated. The pain, numbness, and tingling that follows that path goes down that nerve through your leg. This matters because back pain and nerve compression can be two different problems with two different solutions. We have what we would call bread and butter solutions, which include epidural steroid injections, radiofrequency ablation, and physical therapy. These can be targeted for local back and leg pain. But if the driver of your leg symptoms is a nerve root getting pinched at the L4-5 or L5-S1, these interventions may be not aimed at the right target all the time. You may be treating the smoke while the fire is somewhere else. The check here is to pay attention to the pattern. If your leg symptoms always follow the same path, the same side, the same part of the leg, your body is mapping a specific dermatome or nerve. That's information that's very helpful. And a treatment plan that doesn't directly address the compression driving these symptoms is only doing half the job. Sign number 2, you've been on the same medications for a year with nothing to show for it. If you've been on the same pain medications for a year or longer and you're in exactly the same place you were when you first started, there's a sign that the medications are not managing what's actually going on underneath. They're just masking your pain. So here's what happens over time. Your nervous system starts to adapt. The dose that worked 8 months ago works less now. And the nerve itself, under sustained compression and chronic inflammation or irritation, starts to change how it processes signals. Neurologists call this central sensitization, which basically means your nervous system has been under pressure long enough that it's now amplifying pain signals on its own. The original compression is still there, but now you have an added second layer of nerve irritation acting at the spinal cord level. This can be reversible, but not with more of the same medication. The underlying structural driver, the disc, the narrowed canal, the compressed nerve root, has to be addressed directly. Medications can turn the volume down, but they can't fix what's actually causing the signal. The data shows that when nerve sensitization sets in, the structural driver hasn't been treated, outcomes with medication management alone drop significantly. That's a reason to ask whether the plan you're on is actually designed to change the underlying picture or just manage what you're feeling. If this is matching what you've been going through, drop it in the comments. How long have you had leg symptoms alongside your back pain? I'm curious, how many of you have had that combination explained to you the way I'm explaining it today? Sign number 3, your injections used to last and now they don't. If you've had epidural steroid injections and the first one gave you great relief, the second one a little less, and maybe 3 months or 4 months later, you get the third injection, but it lasts even less. That tells me something specific about where you are in the process. The injections themselves are doing what they're designed to do. They're decreasing inflammation around those nerve roots. That's the target. But the structural problem driving the compression hasn't been addressed. The inflammation keeps coming back because the injection is putting out the fire. The fuel source is still blaring. Patients who've had 3 or more rounds of injections without lasting relief have already hit the ceiling of what we would call bread and butter pain management alone can do for them. And the step most people don't know exists is the one between injections, stop working, and spine surgery. There are very elegant, minimally invasive spinal interventions or procedures at the level of the nerve root, the disc, and the spinal cord itself that are specifically designed for this stage. They don't involve cutting, as much as major spine surgery. They don't involve a 6 to 8 week recovery time. And the data on their outcomes for nerve compression with leg involvement is strong. Think about how interventional cardiology works. The cardiologist doesn't hand a patient off to a cardiothoracic surgeon the moment a stent fails. They go back in, they look at exactly what's happening to that vessel, and they find the most precise way to address it. Same type of logic applies here when it comes to pain and spine. There's a tier of interventions between injections only and spinal surgery that most patients have not been offered. The check. If your injections last under 6 weeks or have stopped working altogether, ask your doctor specifically what structural problem is driving your leg symptoms. Ask what options exist to address that structure directly before surgery is the next recommendation. If all of these signs are present, surgery may eventually need to be part of the conversation. But before you assume that's your only next step, there are 2 things I want you to check first. Before surgery, check these 2 things. Number 1, if an EMG has not been ordered, that may mean the diagnosis may be incomplete. If you have leg pain, numbness, tingling, or weakness, and no one has ordered an EMG, that's electromyography, or a nerve conduction study, your diagnosis may be missing a critical piece. An MRI shows what the structure looks like. It shows a disc bulge, a narrowed canal, a compressed area. An EMG tells you whether that nerve is actually being affected by the structural finding and how badly. Those 2 tests answer 2 different questions, and without both of them, you're treating a picture that's only half visible. Here's why this matters. The MRI may show a disc protrusion at L4-5. That disc bulge could be pressing on the nerve root in a way that's causing real functional damage. Or it could be incidental, and something else entirely is driving your leg symptoms. If no one has checked the nerve directly, the treatment may be aimed at the wrong findings. Patients with leg involvement who've never had this test done are often surprised when they finally get one. It changes what we're treating. It tells us exactly which nerve is involved, how irritated it is, and what the actual functional impact is at that nerve level. That's the information that points us towards the right intervention. The check. Ask your doctor directly whether anyone has done an EMG or nerve conduction velocity study to evaluate the nerve function in your leg. If the answer is no, ask for one. It's a standard diagnostic test for leg symptoms with spinal involvement. If there's a reason to skip it, you deserve to know what the reason is. Have you seen the specialist who handles the space between injections and surgery? If your primary care doctor refers you directly to a spine surgeon, the standard referral path skipped a whole tier of care that sits between pain management and surgery. That gap is why so many people end up in the surgeon's office with nowhere to go. Primary care doctors know how to refer out, and they should be considering pain management, interventional spine or minimally invasive spine specialist, and then spine surgery. And when a patient has back pain plus leg symptoms, a spine surgeon is the first name they may reach for. The problem is that only 8 to 10% of patients who walk through a spine surgeon's door are actually surgical candidates. The rest get evaluated, told surgery isn't right for them, and get sent back to the primary care doctor without any new options. So therein lies the gap. Between injections stop working and surgery starting, there's a whole category of interventional options that most patients are never told about. For instance, spinal cord stimulation works directly on how the nerve processes pain signals without having to cut on anything. Targeted nerve root interventions use image guidance to address the compression point precisely. And for discs, we can do disc injections, PRP, and exosomes. These have real outcome data for this type of presenting complaint. These are minimally invasive. They're designed for the exact situation, back pain plus nerve involvement, the most surgical referrals are based on, and they require a specialist who works in that specific space every day. A spine surgeon's job is to evaluate whether surgery is the right answer. An interventional spine specialist's job is to find out what can be done before surgery is even offered and you're on that table. There are 2 different types of evaluations. And the data shows that patients who go through interventional tier before reaching a surgeon have directly and significantly better long-term outcomes even when surgery eventually becomes part of the picture. The check is this. If your only referral so far has been to a surgeon, ask your current doctor to refer to an interventional spine specialist or pain specialist and ask specifically what options exist in this space between injections and surgery for your exact combination of symptoms. If no one has framed it that way, that's the conversation you need to start. If those 3 warning signs apply to you, surgery may need to be part of the conversation. But that does not mean it should automatically be the next step. Before anyone makes that decision, I would want to know whether the nerve has been properly evaluated and whether the treatment options between injections and surgery have been explored. Sometimes that workup confirms that surgery is the right answer. Other times it reveals that there are still less invasive or minimally invasive spinal surgical options that directly address what is causing the pain. The point is not to avoid surgery at all costs. It is to make sure you're not arriving at surgery because important steps were skipped. If you want to go deeper on what's keeping people stuck in pain management cycles, watch this next. It's called 5 Pain Management Mistakes That Keep You Suffering and What to Do Instead. It covers the exact patterns I see over and over and how to get out of them.